with nursing degrees, people PhD and MD level. We forgot that these are important folks who make sometimes important decisions. In many instances, they're administrators and managers of significant programs. And unfortunately, our education at the university level, college and university level, is not very good. I'm not sure if I can talk across the board for the entire world. In the United States, we are doing pretty poor job training physicians, nurses, psychologists, law enforcement people. We are not doing well. And I'm really glad that we have this session, because we will hear from experts. We'll hear some experiences in delivering education, particularly at the level of the university, undergraduate and graduate level, training in addiction medicine, and see maybe there is something that we can definitely implement in our countries based on your experiences. So I'm very pleased that first we have this session, secondly we have the level of presenters. Speaking about the presenters, trust me, I'm not going to read their bios because it will take me between now and Christmas. These are very prominent people with significant amount of expertise. So they will introduce themselves and will share about themselves as much as they feel comfortable sharing. The interesting thing is that all of the presenters are people that I know, some of them for 30 years. We know each other for a very, very long time. And these are friends. I mean, I'm an old friend. They started probably when they were 6 when they started, but we're old friends and we know each other for many years, and this is an exceptional group of people that you will have really a pleasure and privilege of seeing them live and interacting with them live. So the first presenter is Dr. Sue Galea. She's originally from Malta. She's actually my classmate from the St. George's Hospital Medical School, University of London, 30 years ago. In the mid-90s, we spent some time together in London doing some work. And the funny thing is, we are classmates, and at the same time, one of the next presenters. And I will talk. Yeah, Carmel Clancy, she was actually one of our mentors. So she put up with us. And so this was, you see, there's a long story. There is probably a reason why they choose me to moderate this thing. But anyway, let's start with Dr. Sue Galea. She's a consultant psychiatrist. And she will talk about the addiction specialist fit in the future. What does medical education need to look like? So Sue, please go ahead, and I will go down because I want to see your slide.
You can't see either. Yeah, hang on. Can you hear me? Yeah, perfect. Okay, I might hold the mic. Right, slideshow. Just some evidence that Igor and I have known each other for about 30 years is that he's lost his hair and mine has gone gray. So, yeah. Okay, so today what I'll be talking about is about the addiction specialist fit for the future. And I'm particularly talking about doctors here. I'm focusing this on medical education. It doesn't mean that other professions are not addiction specialists. So I just want to make that clear from the beginning. And by fit for the future, I'm trying to take a bit of a futuristic view to this. So what we train now either makes us fit for the future or not. So I'm going to have that futuristic view as I talk. So this presentation will probably raise more questions than answers. And however, at the end, it does provide some direction to what medical education needs to look like to ensure that we're able to meet the global challenge posed by addiction problems. So this is a bit of a busy slide. So what's the current state of medical education? And as Igor explained, it's often not sufficient to meet the challenges emerging from substance misuse. And this is a global issue. It's not just in one country. And if you look at medical curricula, we know that there's been an improvement over the past decade. However, often we hear quoted that there's about 6 hours of formal teaching within medical curricula with varying amounts of less formal teaching. By less formal teaching, I mean supervision, work-placed placements. This has improved. There's been an increase in the formal hours, largely because there's been learning objectives put in place. And so there's been an increase in formal hours. We're not clear exactly what that increase is, but there has been an increase. And also, there's been an increase in the less formal training. So it has improved. However, we still tend to be part of another discipline. And I often like to say this. It's often mental health and addictions, but actually often it's mental health and additions. You don't get enough of time to train people in addictions. When you look at postgraduate medical education, there's a number of degrees available, and we've heard some of that earlier. So there's master's degrees, PhDs, there's education as part of specialization. So for example, within psychiatry specialization, you can become an addiction psychiatrist, and other examples include, Robert will know about this, so there's the FATRAM, which is the fellowship of the Australasian chapter of addiction medicine. And there's a number of these opportunities available globally. There's also the International Certificate in Addiction Medicine by ISAM, and there's the Universal Prevention, Treatment and Recovery Curricula by ISSUP. Anyway, I can go on. There's a number of opportunities available. There's also a number of opportunities available for continued medical education. There's numerous courses, webinars, name it, you name it, it's there. So there's quite a bit of availability out there. So what we can say is availability has improved, but we're not sure about these. And we heard in the previous session how quality of assurance of content, competencies, and learning objectives remains questionable. We're not sure how to measure that. The suitability of our education methods, are they actually fit for this modern age? When we're still expecting people to come to the classroom, or are we using webinars enough? What are we doing? A lot of people use YouTube clips to learn something. Are we utilizing that? The capacity of education opportunities. So there might be opportunities, but if that is not enough, the end result is still going to be overwhelming, and then you still have a capacity issue on the ground. Recognition of addiction specialists by medical councils. Now this is a real biggie, because you don't get recognized as a specialty of your own right, and there's only a few medical councils that recognize addiction as a specialty of its own right. And is it really true, once an addiction specialist, always an addiction specialist? I don't know. We need to have that continued medical education, but how do we measure that actually there's still competence there? Then it's the applicability of the core competencies or objectives, and evidence-based and values-based. And these last two are in orange because that's largely what I'm going to be talking about given the time that we've got. So I would argue that unless you have clarity that all these points are met, then you don't have the training that makes the addiction specialist fit for the future. So I'll start off by defining addiction specialist. And I took this from some of the work that was done by the Pompidou group. So it's a professional working exclusively in the field of addiction. That they generally have an undergraduate qualification already, and then they need the postgraduate qualification in addiction with the need for continuing education. I did a bit of a content analysis of some postgraduate courses in addiction. And largely, so I divided them up into knowledge, skills, and attitudes. And largely, I know it's a bit of a small writing there, but they cover these topics. So effects, potential harm, and addictive potential of substances, etiology, epidemiology, the usual stuff. Skills, screening and assessment, brief intervention, and then the attitudes where we all know we need to be empathic, supportive, non-judgmental, and that there's professionalism. Largely, they're all the same. And you could do a more in-depth analysis, but they do follow those three areas. Now, probably Igor and Carmel will be familiar with this, because we did have this in our training, where if you try and think about substance use disorders, you can very, very simply have a simple concept in mind and divide it up into three aspects. So you've got the individual, the type of substance, and the environment that, when you put them together, will make the substance use disorder. And I've put this up because I'm going to just have my next few slides to just explain how on the shop floor this could be a bit of an issue. So, emerging trends over the last decade, we know that opioids remain top drugs, but we've heard that methamphetamines and Captagon are on the rise. We know that ketamine use disorders are on the rise. Cannabis remains quite high prevalent. We do know that there's problems with novel psychoactive substances, street benzos, and where I work in Scotland, we've got a huge problem with street benzos. If you take drug-related deaths, about 82% of all deaths have street benzos mixed with opioids in their systems. And now what we're finding is that the street benzos are often laced with synthetic opioids, which makes them even more lethal. And we have other problems where we're not sure with benzodiazepine dependence what the evidence is telling us. Does it tell us that we should detoxify people, or should we maintain people like we do with opioids? So there's lots of gaps there. So by the time I finish my course, and I showed you those three areas, I'm probably already out of date. If you look at the individual, the next arm of substance use disorders, we know that there's more people using drugs. We know that more young people are using drugs and they're more vulnerable. Displaced people, more vulnerable. We've got people coming to our clinics who are telling us, we tell them that maybe cannabis is contributing to their psychosis, but they tell us, but that's not what the internet is telling me. It's telling me that it's okay. So we've got people who are digitally savvy and are health literate, but there's a lot of people with trauma histories, and I didn't see anything in the content that really covered trauma-informed care in a really good way. Then something about the environment. How can I tell the patient that comes to me about cannabis that cannabis is causing them harm when cannabis is being sold in the market against iPhone covers? And it's so easy to get. Over the past few days, I had the pleasure of going around in Thailand a bit. That's Ban Rak Thai, which is in the borders, Myanmar borders with Thailand. And if I had taken that photo in the late 1970s, it would have been full of poppies. And it's now changed. That's all tea tree. And it was lovely, actually, to see that, to go there and see the change, that they were still making substantial money, but it was tea and not opium. So the environment, tells us one thing and then tells us another. So it's quite confusing. Okay, so I took another tack to this. So I thought, okay, let me just go on Google Images and put in addiction specialist and see what comes up. And this is what came up. There's loads of others, but this is just a sample. And it seems to define addiction specialist as a nice person, also with a smile on their face, who's able to talk in a very empathic way. And I don't think we always do that, do we? Even on the phone, she's still smiling. So what I'm trying to say here is that the definition of addiction specialist is not what we learn in our courses. What our medical education tells us is that if we get the evidence right, if we learn about the evidence base, all the research behind it, and we know the process, we screen, we assess, and we're empathic in the way we deliver, then we're likely to have success. But actually, that's not what really happens. On the shop floor, it's not enough. So what is it that we're missing in our training? And I would argue that this is our biggest gap. We need to know the evidence. We need to know the process. But what we don't do well enough is know what the patient values. Okay? We're not just delivering to tables or to somewhere else, something innate. We are delivering to other human beings. And I heard the talk, the previous talk that we had, which was excellent. And they were saying, how do you bring the patient in? And this is what my argument is, that unless we know what the patient values, then we're less likely to have success. And so I've sort of termed it values-based evidence, which would be based on a value-based healthcare strategy that basically is developed around what matters to patients. And if the educational content, the educational matter is based around that same system of what matters to patients, then we're more likely to be successful. And how do we do this? I think this question was branded quite a lot in the previous session. And there's the science of human-centered design, which we don't tend to use. And I would argue that each and every medical education program has to train doctors in human-centered design, because we have to stop doing to patients. We have to stop doing for, and we need to be doing with at each and every point. The other part that I would argue is around innovation. And yes, we talk a lot about innovation, but only a few of us really know what innovation is. It's not just about something new coming on the market. It's actually how do you link in what the research is telling you, the usability, what the patient is telling you, and the industry. Can the industry develop something that makes it easier for people to use? And I think I forgot my phone behind me, but the iPhone is a good example of something that was tested in that way. It was developed, it was put out there, people tried it out, came back, and it was changed and changed and changed till it became a very user-friendly device. So when we talk about addictions, and we're talking about screening and assessment, we don't not just need to ask about the history and how much substances they're using and how long they've been using and how they use them, but we need to think about, should there be a way of us knowing how to utilize patient-generated data that comes to the clinic before you actually see the patient, so that you've got all that information, and then you can utilize that time, which tends to be quite limited, in building that engagement, in getting people on board, and in getting people to actually design their own progress. biomarkers, the Internet of Things. I won't go into these, but this is what we're talking about now. And if you look at the courses, you don't get that at all. They don't train you about artificial intelligence and how speech recognition can be used to prevent somebody from overdosing. You get none of that. So, but yet it's something that's happening now. And as I said, innovation is about having the triple helix of having the patient, having the research, but also having the industry work with you to develop something that's user-friendly. And you keep going down, iterating and iterating and testing it out till you come up with the right product. And I'll stop there and hand over to others.
That was quite impressive, folks. Quite impressive. My suggestion to you, unless you have objections, let's wait until all the presentations are done, and then there will be time for questions, for comments, discussion, because this is what, in my mind, the valuable part of this type of presentation is, the opportunity for discussing. This was wonderful, and one thing I want to emphasize, what you said, is about the engagement. Engagement is a prerequisite for any kind of successful intervention. If the person is not interested in talking to you, forget about it. We are wasting time. So unless the patient is engaged in a conversation with a professional, everything else doesn't make any sense. And this is unfortunately what we do not train people well. One more word before we go to the next presenter. We rarely think that in fact we are dealing with a pediatric condition, because the typical age of onset of substance use disorder is a pediatric age. So in fact, we are dealing with a pediatric condition with a tendency to continue later in life. And we do not train the pediatric nurses, we do not train pediatricians properly to engage this individual much before this person is stuck and significant troubles have already developed. So Sue, really thank you for the engagement, mentioning the importance of engagement. We have a slight problem. What is the problem?
Yeah, I have been pressing the enable.
Oh, that means what happens if you just do okay? Just try.
Okay, well, in the meantime, while they're figuring this technical stuff, we also have only four people staying between you and the reception at 5 o'clock. Okay. And the reception will be happening right here in this big room. So just don't run away from us when we are done. So there will be, at 5 p.m. there will be a reception here. How is it going? Beautiful. So now we hear from two of our esteemed colleagues. These are two people who, in my mind, they're doing phenomenal work in the area that is commonly overlooked, training for nurses. As we said initially, even training physicians, we are not very good in doing that, at least not in the United States. Training nurses, even in worse situation, frankly. Again, I don't know about the world, but in the United States, the addiction part of the curriculum for nurses is minuscule. And in some schools, they even don't exist. So the two people who will be presenting next, and they will be talking about the International Nurses Society on Addiction and the work they're doing in terms of the nursing education is a revolutionary work around the world. I don't know anybody else who is doing it with that systematic approach. So I would like to invite Dana Murphy-Parker, and after Dana, my old friend, she's young friend, I'm old, friend Carmel Clancy will come and will continue. So this will be a joint presentation between these two ladies, and I'm very, very thrilled that we will hear something that we typically do not hear, the nursing education.
Okay. Thank you so much, Igor. And it's so nice to be with all of you here in Chiang Mai, Thailand. I can't pension myself that I'm here. But yes, this is exactly what Carmel and I would like to talk with you over the next few minutes about. Leveraging the nursing role in addictions, because I can tell you that Carmel and I, we've been working together for 25 years. We met in 1998, and our work started then, and it's continued, and it's been about educating nurses about their role in taking care of people who have substance use disorders. So what we're going to tell you about very briefly is a little bit about the history of the International Nurses Society on Addictions. We're going to examine how INSA actually emerged internationally, and why leveraging the role of nurses is very important and imperative. And then we're going to review, Carmel's going to take over and review the INSA global collaboration with global nursing organizations and the global nursing organizers and organizations, and then reveal current work that we're doing to develop an international certification exam. So we'll start with just discussing the history. This is a timeline. So the International Nurses Society on Addictions became the International Nurses Society on Addictions in 2020. And before that, it was started actually in 1975 as the National Nurses Organization in the United States for Alcohol. And then a few years later, they did change it to the National Nurses Society on Addictions. There were two other professional nursing organizations in the US, so they decided to merge, and when they did, they had made a promise to each other that they would change their name internationally, or they would change their name. And they changed it to the International Nurses Society on Addictions, which I have to say at the time, I was not really crazy about that idea, because that was 2020, and I'd met Carmel in 1998, and we had started kind of collaborating with other nurses in other countries who were working in the area of addictions nursing. So I just wanted to show you that timeline. This is a favorite quote of mine, and I use it all the time. I've been in nursing academia for about 22 years now, and I always teach my undergraduate students and my graduate. I'm a psychiatric mental health nurse practitioner in the United States, and my graduate students, I always teach them about addictions as a healthcare issue, because they don't think about it that way because they haven't had the education. But this quote, it comes from one of the first books that ever came out in nursing, and it says, nurses are in an excellent position to recognize the use and problematic use of alcohol and drugs in people. Nurses skillfully manage the complications of problematic use, such as liver disease, peripheral neuropathy, and trauma, yet they are not adequately trained to identify the root of the problem and intervene in ways in which direct people into treatment. And this other quote, to treat the hemorrhage of the pancreatitis and not the alcoholism is poor health care. I mean, can you imagine if somebody has anemia and we don't try to find the root of the problem, what's causing the anemia? But we do this all the time with substance use disorders. People come in with cirrhosis, pancreatitis, lung cancer, from smoking, and we never go to the root of the issue. So what happened, as I said, Carmel and I actually met in 1998. It was sort of a serendipitous meeting in which it was the Association of Nurses in Substance Abuse, which Carmel was president of, which was in the UK, England at the time. This was in Nottingham. And a few of us just had this discussion about how nursing education was missing in nursing curricula. And so kind of move along and speed things up a little bit and move forward. The International Council, which is the mothership of all nursing professional organizations around the globe, each country, like mine would be the American Nurses Association, Carmel's would be the Royal College of Nursing of the UK, and whatever country you're in. The ICN, the International Council of Nursing, was going to celebrate its centennial conference in London in 1999. And so we decided to see if we could work with the ICN organizers and plan a meeting to talk about addictions with nurses. And we did do that, and it was really quite amazing what happened. We were able to have a meeting. There were about 50 nurses that came to that meeting, and all we did was we put up flyers around the venue where the ICN was in London. And we had about 50 nurses come to this meeting from all different, countries all over. And it was really a very stimulating conversation. But a lot of the gist of it was, we don't really know anything about it. We want to take care of people, but we've never had any education. So we do have a publication from that, and that's back from 1999. So, what happened was, and I have the timeline up of INSA and where we have come from and where we're going to. But even when they changed their name in 2020 to International, behind the scenes, some of us were doing international, we were kind of an underground nursing, doing international work together with still the goal of raising the visibility of the role of addictions nurses and to, try to get nurses educated in this area. So after we had the ICN in London, it was so well received and all, we decided to do it again. The next ICN was in Copenhagen, Denmark. And we went there in 2001, and that was a very successful conference. And actually there, we met a woman by the name of Charlotte de Crispiny. I don't know if any of you know University of Adelaide at the time. I'm talking back in 2001. But Charlotte invited us, and we had a joint conference with what we called ourselves as the International Network was 10. And so we had this joint conference in Adelaide, Australia, and again, brought nurses from all over to talk about the role of addictions nursing. So I just put up some of the publications that we had here. And also, at the time, there was a journal in the UK, the Drug and Alcohol Professional. David Cooper was the editor of that journal. And he offered to do a special publication on the papers that we had done in Adelaide. So we were very, very happy about that. And again, it just really put the word out there, raised the visibility a little bit more. And so we just kind of kept going. This is a document that came out that was written by actually a nurse up in Scotland, Hazel Watson. It was a WHO paper. And this was from the year, it goes way back, I can't see it right now, but quite a while back, but the involvement of nurses and midwives in screening and brief intervention. And again, talks about the lack of education that nurses get within their education curricula. So we were on this, and I take you back to this slide only to remind you that between 2000, when they changed the name in 2020, they called themselves the International Nurses Society on Addictions. However, it was a United States organization, and it really wasn't international. In 2012, I was elected as the president-elect for INSA, and I'd been working with Carmel, and I knew Carmel, and I said, Carmel, you've got to come on board. You've got to get involved now with INSA, and you've got to help me to open up the international piece, and we're going to do some things internationally, or I think we should just go back to being the National Nurses Society on Addictions. And so Carmel came on board. We had a retreat in 2013 in Philadelphia, and it was at that retreat that Carmel actually proposed that we model INSA after the World Health Organization, that we look at the different regions and try to reach out to nurses in those regions and develop chapters. So that the board bought it. It was great. We had the support of the board, and that was really beginning of the international collaboration. Okay, so that was about 2014. And then, I talked about the ICN and our involvement with ICN, and Carmel will pick it up and tell you a little bit more about it. But we were absolutely thrilled because we did the ICN in London, we did it in Copenhagen, and then we did it again in Taiwan, sorry. And that was in 2005. And then we were sort of, just working. What had actually happened is that the American Nurses Association president, Pam Cipriano, who served 2 terms, then was elected to the board of the International Council of Nurses, and then she is currently the president of the International Council of Nursing. So we were thrilled because we thought, well, now we've got a real friend in nursing, right, at the highest level possible in nursing. And Carmel and Dr. Stephen Strobe, who was the president after me, he took over in 2016, we were invited to go to the ICN, which was held in Barcelona in 2017, and again, talk about the role of nurses in addictions and you know, just spreading the word and raising the visibility that this is within our role and we should be doing more than we're doing with it. And so we've made some difference, but we still have a ways to go. I just want to read this thing to you, and then I'm going to turn it over to Carmel, because this was so touching to me. This was a nurse in Adelaide, Australia in 2003 with this conference. And she summed it up so well, and I'm just so glad that we captured it. She said, "I've never been to an international nurses conference before, and while I am taking home lots of new ideas and lots of new knowledge, what I am really taking home with me is the ability to network on an international and national level and to just really feel pride in being a nurse and part of a nursing workforce across the world." And that really impacted me over the last 2 mornings when I've watched on the TV while getting ready, and I never usually watch TV, and I certainly seldom watch the news, but what was highlighted has been the plight of the little boy in Baghdad who lost both his arms and 80% burns to his body. And they talked about the nurses in Baghdad advocating to get him moved to Kuwait, and that actually happened, and he had surgery that was needed. And both times I saw that, tears welled up in my eyes because I realized nurses truly can make a difference. And there only may be one of us in one area, but individually and collectively, we are making a difference. And that is what I'm taking home with me from this conference, and I thank everyone who has made these last 4 days happen. It's been fantastic. And I thought she summed it up so very well. So thank you so much, and I'm going to turn you over now to President Carmel Clancy of INSA right now. Thank you.
Thanks, Dana. Oop. Thank you. So thank you, everybody, and thank you for your attention. And Dana has kind of given you, I think, hopefully a whistle-stop tour of the last 20, 25 years. And I think the importance of that sort of pre-presentation in terms of leveraging nurses, it just shows you it takes a while. I feel I've been sort of saying the same thing for 25 years. And that's kind of sad on one level, but on another level, it's getting there. And there has been sort of little movements and little process, you know, sort of forward steps, but we still have a long journey to go. And I think that one of the reasons, or one of the ways in for nursing, is that we know stigma is very much alive and well. We know that people often really don't figure out and really want to know why we should be working with people who are perhaps using drugs in a problematic way. And that's my experience, whether I'm talking to doctors, nurses, pharmacists, psychologists, they pretty much all say the same thing. Why do I have to do this? Isn't it somebody else's job? And so there's a real importance about how do we leverage this conversation? How do we get education in? How do we let people know that this is their role and it's legitimate for them to do this and it's not just an add-on? And one of the ways of doing that, in my view, particularly for nurses who may not necessarily see they have a role with addiction per se, and working with people with problematic substance use, but is actually talking about health in general. Talking about public health, talking about the Sustainable Development Goals. People are very focused in on this, certainly at a government level, and they're very interested in anybody who can help them move their goals towards the right targets. So if we start actually talking about, yes, addiction is an issue, but actually do you know that one of the biggest killers is non-communicable diseases, as we know, and that's what's affecting mortality and morbidity within our planet. And would you like us to help you with those targets? Would you like us to do something about those issues? Then maybe the conversation turns into a much more two-way street in terms of, okay, now I might see where I might need to put nursing education and particularly addiction into a curriculum. Because if I just go in and say we should all be helping people with drug use because it's a good thing to do, people shut down on me. But if I go in with a public health message, if I go in with the SDGs and targets, people think, okay, I see where, even though my curriculum is crowded, I see why I might need to do that. And particularly if you start to make those directions, it's a very busy slide, but it's a really good way of showing people how non-communicable diseases, and particularly addiction, impacts on non-communicable disease. And if you start that conversation and saying, okay, so what are you doing on your curriculum around non-communicable diseases, and how many things are linked to smoking, how many things are linked to alcohol, how many things are linked to substance use, all of a sudden people start to make those connections with you. I'm sure they knew it, but it's a way of actually opening a conversation when you're thinking about nursing education. But I would suggest, particularly any education that's more clinically focused, this is the sort of language people seem to wake up to when you're talking about their curriculum and curriculum development. So just as a point, this is one of the things we need to be thinking about, because if we're going to move the dial, whether we're going to move the dial on SCDs in terms of non-communicable disease, or if we're going to move the dial in terms of addiction, this is the sort of thing we can start to say. If we have greater impact on NCD, you're going to have a reduction in drug and alcohol use. So it's really just as a starting point and a kick-off point in terms of curriculum development. I said it earlier in another session, but if you're not aware, there are 27 million nurses in this world at this moment, registered and working, okay? 27 million. That's a workforce that you should be tapping into. And if you haven't thought about that, please wake up and think about it. 27 million people, even if a small percentage of that were educated in terms of drug and alcohol and its connection with the NCD argument and subject, can we only imagine what that might do now in terms of public health and impact and awareness? It's phenomenal. 27 million nurses makes up 50% of the global health workforce. Half the workforce in the world are nurses. Please start mobilizing your workforce because they will be able to make a significant difference to your country and to your health of your country. So really important. We all know about the iceberg, don't we, in addiction, that, you know, that iceberg is pretty phenomenal. And usually we're only thinking about those that are at the tip of that iceberg that we can see. But if we can again go in with the fact that it's below that level, what are we doing about that? If we can get in at the prevention, if we can get in early detection, that's what nurses generally can do, and they're really positioned, and they're positioned everywhere. They're positioned in schools, they're positioned in prisons, they're positioned in emergency departments, they're positioned within the primary care system. They are at that generalist level where people are just starting to come in to say, I might be overusing here, I might have some challenge, I'm a bit stressed, I've had trauma, I'm drinking a little bit more, I'm smoking a little bit more. If we can get in at that level, think about how we can reduce that iceberg and that tip that's coming into our acute services around the addiction specialist. So again, the big message, and I'm sure we all know it, WHO says it, no health without a workforce, no workforce without nurses and midwives. So I'm banging the drum, 27 million nurses, please start thinking about them and think about their impact that they can have. Investing in nurses and midwives is good value for money. Actually, sadly, and I'm sure many of you will know, nurses are not well paid across the globe. In actual fact, they're abysmally paid for the job that they do. And I think if you look at the pandemic and you look at what nurses did along with other, obviously, health professionals, you know, that clap, that I don't know if that happened in your country, but people were clapping in the UK. Yeah, and it lasted. Don't clap me, pay me, because I'm doing a really good job. And I think nurses need to start stepping into that. We need to start thinking about how we remunerate them. But they still are very good value for money for what they do. So if we're going to do something around education, one of the things, and Dana gave us a lovely example of that collaborative point, collaborative advantage, which is defined as that gained by working together to achieve more than is possible on your own. And that's really what INS is about. That's why we're delighted to participate in this particular forum and this network, because it is about the coming together. If we come together, our voice gets much, much louder. So we're currently now working, since we went more into the international side, we're working with all of these groups at the moment in various degrees of activity at the minute, but we're really quite excited about the possibility of what we're doing. And one of the things that we are very excited about is we have affiliate status with the ICN. So that ICN is a portal into roughly about 126 countries. So they have that connection, and the current president, who is Pam Cipriano, she has, very, very good friend of ours, would like to work with us, would like to push the message about nurses. So if anybody wants to talk to us about how do we get action and traction in your particular country, or you would, we could help in any way, please do talk to us, because we are connected in, obviously, with the ICN. The other thing that we're also trying to do as a society, because it is about coming together, is we've actually gone for a fair price model, because we know nurses can't afford to be members of societies. It's a big thing, a society. In the US, you see a lot of societies, professional societies. You see it in Australia, you see it in the UK and certain parts of Europe, but not the rest of the world largely, because it's expensive. So we've done a fair price modeling. So if you come from lower economic countries, we actually will not charge you to be a member. You will have to buy the journal, but that's only $20 for the year. Then we actually will allow you to come in, take a seat at the table, and open the conversation with you. So we're doing our best to try and bring people in, and as you can see, this is our footprint at the moment, and in the red, these are people who are coming forward, trying to come into the network and hopefully start working with us. So we're really excited. So just as a reminder, just on the education, and I'll take you then just for the last few minutes, what we're trying to do now. So 3 reasons often we hear, this is Shaw's work going back to the 70s, 3 reasons why people don't work with drug users, okay? One is that they actually don't think it's legitimate. It's not my role, it's somebody else's role. Oh no, the doctor does that, or the social worker does that, or the nurse does that. Not my role, nobody trained me, actually. That's why I don't think it's my role. Nobody actually told me it's my role when I was being trained. But they also actually say is that I don't feel adequate. I don't have the skills, I don't have the training, maybe I'm not fit, as Sue has just told us. Really important, I just don't feel fit for the job. So please, I'm not going to ask the questions because I don't know what to do with the answers. But if they get role support, and so if they have role support, they get the training, and they're told in undergraduate, pre-service education, that this is a legitimate role for you, then you get engagement. And those are the 3 domains that you need to be thinking about. But we have problems, and we've already heard it right across the disciplines. I won't go into detail, but you all know, really, it's miserable. Very, very little education. In actual fact, we've heard doctors formally 6 hours, nurses probably 3 hours and less. 3 hours or less. Mad. And the other challenge is we've insufficient numbers in the universities. Don't know about your university, but we don't have an awful lot of faculty trained up. So very difficult then. If you don't have the faculty, who's going to develop the curriculum for you? So this is where these networks, and particularly ICU DDR, is imperative, because we can come together as faculty and really help each other where we don't have faculty in situ. We also don't have sufficient placements, practice specialist placements, for our students to go out and learn in situ. So big problem on that. And then we feel we don't have enough addiction nurses, so that's something we're trying to work on as well. So those factors, unfortunately, don't help. But work is underway, so I just want to draw your attention to a couple of things that are happening that may be of use. So we do have a scope of standards. It's largely based on an American standard of practice, but it's a good starting point if you want a reference point, and that has come out now. It's in its 3rd edition, and it's just recently been published in association with ANA. So there's a nursing addiction scope and standards of practice. We also have one in the UK, which I was party to working with, which is the role of nurses in alcohol and drug treatment services. And then there's DANA, which is the drugs and alcohol nurses of Australasia. And they have standards. And there is some actually in Canada as well. But those 2 that I've just given you, the first one you have to pay for, the scope of standards, but these 2 are free and downloadable. And if we're getting these slides, please, you can check those out. They may be useful for you in your respective countries. So the good news is all of this work and this collaborative advantage has just taken us to a point with our particular collaborators, GCCC, Colombo Plan, and with the funding and support of INL, so my gratitude obviously to colleagues there. But we've now started to work with GCCC to develop a global certification for nurses, and it's going to be level 1 and level 2. So level 1 will be for any nurse, because our motto in INSA is every nurse is an addictions nurse. So basically we start from the premise every nurse needs to have a basic awareness and understanding. So we're going to be doing a level 1 certification. We're working on that now. We hope to have it ready for next summer. And then level 2 will be for nurses who've already become specialists, who've been working for addiction for about a year in the practice, and they will have a level 2. So we're currently working on the competencies for that and tests, or, test questions and so forth, and that hopefully will come out as a product towards the end of next year, summer to autumn of next year. So in order for the framework, we're saying and training, a proposal of key functions and activities are being developed, and we're currently doing that. And then you can see that we're also, and I know my colleague is here from the WHO office and the pre-service education. I was in Geneva a couple of weeks back. They're doing some amazing work on competencies there. So hopefully we'll tie in with that as well. So everything starts to come together and it looks like we're all doing stuff on the same page. But there's lots and lots happening over the next year. So please watch this and keep in touch with us. But we hope in the ISUB meeting in Athens, not Athens, Thessalonica, I believe, in Greece next year, we hope to have potentially a course that will prepare people for that test. So this is the plan at the moment. We're working on it behind the scenes. But if you wanted to know, there is already a credentialing that's going on, largely for nurses in the US and Canada, but it's called the CARN, and that is a first iteration, really, of credentialing for nurses that's come out of the States, particularly in the earlier days of INSA. But if you were interested in that, you can check that out, but there is one already that exists. So we're here hopefully to say to you, we're committed to assisting. We're an expert group of addiction nurses globally. We're an expert group of addiction nurses who are also educationalists, so we're really happy to work with you on curriculum issues. And as a society, we really are open to all nurses, offering support, coaching, mentoring, online platform. We have educational materials. We have a journal, which is Addictions Nursing. And we are a specialist affiliate with the ICN, which is a real portal into other nursing organizations. So I think that takes me to the end. I'm just going to give you, I'm not going to play it, but if you get a chance, and happy to give out cards, we have a lovely little video on YouTube which actually shows you a little bit about the organization, and it's kind of fun, and certainly I direct you to do that. So thank you, colleagues, and thank you very much for listening.
Wonderful, wonderful, wonderful. It's a pretty impressive work, would you agree with me? Working with nurses is, and something that I had no idea that there are that many, 27 million nurses. I had no idea. I learned something. How many addiction psychiatrists? A good question. I don't know the answer. But 27 million nurses around the world, this is really a huge workforce that we are really missing the opportunity if we don't train them properly. And these are people, I mean, people first will go to see a nurse or a general practitioner much before they'll come to see me as an addiction psychiatrist. Who cares about what I think? But they will be forced to go to the general practitioner or to a nurse. If we don't train them well, we are missing the opportunity. Wonderful presentation. So we have two more presenters, and then we'll have a discussion. Our next presenter is Dr. Robert Lee. He is a senior researcher from Australia, from Adelaide, not Melbourne, not Sydney, Adelaide. Yeah, I'm sure you know his name. I mean, if I try to present the impact he made on the field of addiction medicine, that will be a very long time. Those of you who are familiar with the ASSIST screening and assessment tool, well, if you don't like it, this is the guy to blame, okay? All right, so you have an opportunity for that. So it is really pleasure to invite Robert to the podium. You have your slide, or you don't? Okay. So Robert will be talking about medical education for addiction in Australia. Some examples of undergraduate and graduate work in his country, please.
Firstly, let me thank the organisers for the opportunity to talk with you, and let me thank the previous presenters for setting the stage for what I want to talk about, because it sits very comfortably with the tone of the issues that I want to discuss. Australians love drugs. They've always loved drugs. We were founded on drugs. When the British invaded Australia, claiming that nobody else was there, denying our first inhabitants, the colony was formed on rum. And so we have a very long association. Most of us are drinkers. Tobacco is on the decline, but vaping is on the incline. And about 40% of Australians have tried an illegal drug at least once in their life. So it would be unusual for an Australian to say they don't know anybody who uses drugs. Of course, there's good drugs and there's bad drugs. And the good drugs are the legal ones and the bad drugs are the illegal ones. And so most people don't consider alcohol and tobacco drugs, which is a fundamental issue. And that's not just the general public. It extends right into the roots of nursing and medicine and psychology and the other domains which might show a professional interest in this. Unfortunately, at home, there's a very long delay between the time somebody starts to have a problem and they actually get help for that problem, typically around 18 years. And that, in fact, is pretty much the mark universally when you compare other country studies that have done similar work, looking at delays between commencement of problem. The range is usually between 15 and 20 years. So this isn't unusual. This is usual. And that's because the health system pretends it's not their business. And we've already heard about that. 27 years ago, I was invited to a meeting in Geneva to talk about the fact that WHO had an instrument for screening for alcohol, but they had nothing for drugs. And so a group of 4 of us sat around a coffee table and decided that we were going to do something about that we were going to work on developing a screening instrument that could be used by non-specialists. We would take a major leap forward and not only talk about assessing severity of risk, but we would also link that to an intervention which was based upon that severity. And we would be particularly interested in those people whose problems weren't so serious that a brief intervention would work, because we know brief interventions don't really connect well with people who have serious problems. They need more intensive treatment. And what we wanted to do was to be flexible enough to fit within the framework of any substance in any country which might likely be a problem. So in Thailand, kratom might be something you'd be interested in, whereas in Australia there'd be no interest in kratom at all because we just don't see it. So the salience of developing the instrument is important, but the audience was an audience who already decided it's not my business. We're aiming it at non-specialist services, primary healthcare services, and other services that would see people who are likely to have problems. The architecture of the instrument is really designed to firstly filter out that minority who've never ever used a drug in their life, and I've already said to you that's a low number. Focus on the previous 3 months because we know that has salience. That's likely to mean it's important to that individual. And so whatever response we provide is going to be contemporary to the issues at hand. And then to pan out to lifetime again, place a greater emphasis on recency. 2 key trigger points: concern by others. Everybody else knows you got a problem before you do. It's just you're one of the last people to think maybe it is a problem. And then that issue about trying to control, cut down, or stop using, and you didn't quite get there. So it's that feeling of, I'm trying to do something, but it's not working. So the architecture of the instrument was pretty well straightforward, and we did multiple studies in multiple countries, and we validated it, and we connected it to an intervention which was based on Bill Miller and Martha Sanchez-Craig's work, using the frames model of personalising feedback, and then ensuring they are in the driver's seat. What do you want to do? We're going to work this. So this co-designing the intervention is an important principle, providing simple advice, and then strategically a menu of options, because when you're told the choice is do this, people will usually back away. They like to feel that there is choice. And we've talked already about empathy and how important that is in client engagement, because if people feel that you don't hear what their problems are, that you understand them and you can feed it back to them, it's never ever going to cut through. So the assist is basically aimed at that moderate risk group, that low group, or that large group of people who are appropriate for a brief intervention where we know in a non-specialist setting that that will work, or if they're more serious problems, encourage them to go to a specialist service and get an assessment, and then maybe connect to an appropriate intervention. So that's the architecture of what we designed. And people loved it. In all of the research studies that we've done, we've had people come back and say, the majority of them tried to cut down or stop using. We had data that showed that it worked, and we were happy. We felt satisfied. And then we realised there were problems. And the problems were numerous. I'd have to say number one, top of the pops, is stigma and discrimination. We don't have those kind of people in our practice. We don't see those people. Well, actually, they do come to your practice. They just don't tell you about that problem, because if they did, you show them the door. Or commonly, the people that I see who've got very serious problems, they've got their drug doctors, that's the doctors they go and see for their drug problems, and they've got other doctors they go and see for other health problems, and they never confide across what those two things are. We heard about the attitudes issue. Key opinion leaders, if you've got people in leading a clinical practice, most of our office-based practice in primary healthcare is now corporatised. And so if the corporatised leader of the practice says, we don't want to treat that, then it's an active disincentive for all the other people. And of course, there are all concerns about legal risk, about what happens if somebody tells me about something they're doing with an illegal drug? Do I have to report them, or do I need to bring the police in? And all those issues are easily dealt with, and they are legitimate concerns, but it becomes a barrier to using it. Information channels is interesting because, of course, we're now connected up in many countries. Electronic health records are a reality. The ability to share information real time is a reality, but it's about inserting what we know into those information channels in a way that can be useful. And so I'm going to come back and talk about that. And governments are kind of supportive, but they're kind of not. You know, we've had the tough on drugs, we've had the war on drugs, we've had governments talk about how they want to respond to the drug problem, but really most of the money goes to enforcement, and very little of it goes into treatment, and virtually none of it goes into the general health and welfare workforce on building capacity in that area. And so the infrastructure to support it isn't there, and what people do in the real world often doesn't reflect what we as scientists might develop. So that fidelity of practice is lost, and that creates a real problem where people start off with a good intention and they kind of lose their way. And then training. So what I'm going to do is hopefully walk you through that list and what we're doing in the future to try and address those issues. And how, I'm going to talk about successes, I'm going to talk about partial successes, and I'm going to tell you about some complete failures. But I think it's important that you have a concept of so what's really going on with us. So, first thing, 99% of doctors, when we showed them the assist, said, it's too long. I don't want to do it, right? I've only got 7 minutes and you want me to administer that form. So we worked with the production team, we redesigned the form, so we nuked the WHO form, we turned it into a one-pager so it doesn't look so long. We've developed electronic formats of it, and then John Marsden and I got really clever. We decided we get the 4 phases of the original studies, pull all the data together, and to do a factor analysis that would identify the top 3 questions for each substance that would identify caseness, where each drug has its own unique footprint. So there are 3 different questions for each of the drugs, and that way we reduce burden of time. Where is that important? Emergency departments because of high prevalence of presentation, and antenatal services because people get churned over very quickly and they get seen by the midwives, so we focused on the midwives. So let's just talk about that for a moment. So all of this is downloadable on our website, and I'll give you the URL later. It's an ultra-rapid screening instrument. It takes about 3 minutes to administer. It's been validated for self-report. It really does work in those time pressure areas. It's brilliant for repeat measures, so the 3 trimesters of pregnancy, you can track people over time. And we're currently doing a study in an antenatal setting where we've done pre-training. So we did a case note audit. Less than 40% of case note records had any documentation of any substance in them as part of the first antenatal visit. We've done a training needs analysis of the midwives. We're about to go and do the training, and then we're going to follow it up and see what impact the introduction of the light into the electronic health record has in changing what happens. We did a study at the Royal Adelaide Hospital. I'm not going to go through all the detail, but 40% of the people sitting in the emergency department waiting to be seen by a doctor, 40% of them were in that risk range of moderate risk. And the majority of those, it was only for one substance. The staff in the hospital were astonished because they thought it was around 5%. So what they do, and I liked your iceberg, what they do is that they can spot the serious problem from the other side of the room. What they ignore is the bigger problem under the waterline, which are people who've got moderate level problems, which has contributed to the reason they've gone to the ED, so that if you can intervene with those people, they don't need to come back again. And so we've encouraged them to think about how we might do that. They still didn't want to do anything because they're busy people, and they are. Anybody who's worked in an ED knows how busy it is. So now we've got QR codes on the wall where people can put their smartphone on the QR code, they can do a self-assessment, and they can talk to the person in the ED about what the results showed when they go through the door. The second thing that we did was we realised that even though we'd done a multi-country study which had complied with WHO standards and was seen as culturally neutral, our First Nations people said, but you didn't validate it in our community. So we've done a cultural adaptation as a co-design with the Pitjantjatjara community in Australia. We followed the WHO protocol. We've worked with the elders. They told us the questions were too complicated in their language. We've had to unpack the questions and realign them to make them easier to understand. We've put it into an iPad because Pitjantjatjara words are like Thai words. They go for a long time. And We're doing it in spoken and written word, English and Pitjantjatjara, so they can listen to it in whichever language they choose. They can read it in whichever language they choose. And because literacy is an issue, we've worked with an Indigenous artist to do graphics that demonstrate the intention of the question so that it's easier for them to follow and for them to understand. We're about to focus group test this, then we're going to validate it, and then we'll make it available. We've also recognised, as we've already heard, it's not just old people who have drug problems. It's actually a lot of people are with youth. So we developed two versions for youth, one for children 10 to 14, one for adolescents 15 to 17. We've just validated the adolescent version with the Spanish criminal justice system, and we've submitted that for publication. Both of these are available. The questions are different because the problems are different. So we've redesigned the questions and we've redesigned the intervention. We've removed the questions that didn't make sense and we've inserted questions which do make sense for that aged population. We've had pushback on implementation. Youth services don't see it as their job. And it struck us as extraordinary, yet youth criminal justice services willingly embrace it because they see it as part of the preventing reoffending approach. So this is an area where we've developed a resource, we've shown that it's youth-friendly, we've worked with youth services. It's mandated in my state that all community youth workers have to be trained in this. They can't go out and work as community youth workers unless they have. But every other state in Australia, we've got pushback. They just, they all tell us that they've got their own approach. And when I have a look at their approach, they actually don't have an approach. They don't connect a systematic appraisal of severity of risk to an appropriate intervention. We also realise that in Australia, drug and alcohol is actually public health. It's not mental health. And so I'm a public health physician, I'm an addiction medicine specialist, but I'm not a psychiatrist. And most of our mental health services lost interest and capacity for responding to substance use, even though it's a very common coexisting disorder. They don't actually recognise that both conditions make the other condition worse. So we've recently developed a resource on screening and early intervention in specialist mental health settings. It's got 5 case scenarios that any community psychiatrist, community mental nurse would recognise instantly as, this is our kind of problem. This is not a general practice oriented mental health service. This is for specialist services. And we're now working with the chief psychiatrists in every state and territory in Australia to do introduction and scale up across their system. So in Queensland, they've introduced it into their routine service, and the other states are still in the thinking about it. The other group that we're focused on is the elderly population, because being amongst that group now, I know risks of falls and injuries are real if you take a substance, right? And we're seeing this in aged care facilities, that they're concerned about psychotropic medication, alcohol in particular, but medical marijuana is also creeping in, and so that becomes a falls risk. So we're developing an intervention based upon, and we're changing the questions, based upon populations who are as old as I am. So that's work in progress, but I'm really excited about that because that's a population that was completely ignored previously. We've got 2 websites, one that's aimed for people who do things, one phase aims at people who either are concerned about their own substance use or somebody else's substance use. All of our materials are free and available. We've got smartphone apps that you can use, that you can download both from Google Play and Apple Store. We've got self-help materials. We've got a resource developed for nurses specifically. We're just starting our 3rd edition of that. And I will send you a copy of it. So we have also focused on substances, so methamphetamine. We've translated these materials into different languages so that they're available not just in English and for specific settings. Draw your attention to this one. This is a searchable bibliography. So every single publication that has anything to do with the assist, good, bad or ugly, we update this every 6 months, and it's a searchable database. So if you're interested in paediatric substance use with the assist, you can screen it and it'll pull out all the publications, and if it's available for you, your hyperlinks will take you directly to the publication. The other one that we've got is Assist Plus. This is aimed at consumers. So we've got some videos on there. We talk to how to raise the issue. People who are concerned about friends or family members and they don't know how to actually raise the issue. What are the steps you would go through? And we've done that as a video so that you can see that. I should say on this one, a lot of these videos are short links, but they're also longer instructional videos. So we think showing somebody how to do it is a lot more important than just telling them how to do it. So the Assist Plus is about also checking up about substance use information, because Dr. Google tells a lot of lies. We get the same issue that they come as, oh, no, I was told. So we have authority facts, and we happily engage with consumers in discussion about misinformation. So recently we've added some new substances, new and emerging psychostimulants, big issue, chemsex, big issue. So we've delved into that, and we've redesigned the original workbook that we developed for WHO. We've redesigned it as downloadable PDF files that you can say, look, I'm not sure whether I want to cut down. There's a single sheet you can download and you can use it as a worksheet. So we found that it needs to be much more engaging and interactive with young people, because if it's turn the page, we're not interested in it. So finally, just talk to you about how we're going about building capacity. In Australia, the current government has got a network of primary healthcare services called Primary Healthcare Network. So large areas are oversighted by a supervising network, and they ensure consistency and collaboration across all the primary healthcare workers. There are 35 primary healthcare networks in Australia. We connect directly with each of them. We provide them with opportunities for training. We do a 3-step model. We'll provide online Zoom training for people, which is basic information and facts, how to do it. We'll show them a video so that they can see how it's done. If they want to do skills-based training, managing resistance, managing change, practice reform, it's got to be face-to-face. I can't teach skills over the internet, but I can do it in a room. And so we will do either a 2 or a 4-hour session, because that's about all the time we're going to get out of people. And we will focus on the major skills that they need, which is all based upon behavioural intervention. And then we follow it up 6 weeks later with another Zoom meeting, and this time it's how did it go? And what we do is we listen to, well, it worked really well and then something went wrong. And so we talk about the problems. And if they're reluctant to do that, we've got a list of problems. And we'll say, well, did any of you find that went wrong? And, oh, yeah, I found that went wrong. So we then talk about the solutions, the workaround solutions. If you don't follow people up, they try it, they trip, they fall, they go back to what they did before. So it's critically important to maintain commitment. We're also connected into the colleges, so they get professional development points. But truthfully, what I'm really after is that I'm after the doctors to give me permission to go and talk to the practice nurses, because they do it better, a lot better, right? They're not in the business of telling, they're in the business of listening, right? But I found that unless the practice leads agree, it doesn't happen. And we're moving our way into the National Electronic Health Record Base so that the assist will be fully integrated. It will be shared, and you can upload it off your phone onto your own electronic health record. So the doctor doesn't need to go and do it. When they come in there, a flag will come up that you've done an assist, and it'll show up. And we're working with state governments, because if you don't, they undermine you. They say it's not important, but actually the state governments have been pretty good in terms of connection with different opportunities. This one on the bottom, that was the Western Australian state government. They were so pleased with the idea of the QR code in the waiting rooms, they developed their own. They put them in every hospital in the state, so everybody can go and do their own self-assessment. Our federal government's important. We have problems with returned servicemen who have post-traumatic stress disorder and have a lot of substance use, so we work with Department of Veteran Affairs. And we have a lot of current serving Defence members, so we're working with the Department of Defence, training their counsellors on how to deal with it. It's interesting, Veteran Affairs, happy to talk about drugs. Department of Defence, happy to talk about alcohol. Not so happy to talk about drugs. So that's a conversation in process, because truthfully, there's a fair amount of drug use amongst serving personnel coping with what they're doing. And higher education, I'm going to finish on this one. The College of Addiction Medicine is now realigning its training course to be competency-based training. So that's going through a process of active revision now. All of our colleges are moving towards competency-based training, so we're not leading the pack, we're just part of the game. And competency-based training is a hell of a lot more difficult than just the way that I was trained. There's a lot of material available at the higher education level. The previous Minister of Health, on my request, wrote to every dean of every medical school, nursing school, and school of psychology, asking them what contribution they had on training for screening and early intervention for substance use disorders as part of their curriculum. And if they didn't have any, then they needed to contact us so that we could provide the materials to them. Interestingly, my university, we do better than 6. We're pretty close to 12. I teach in 4 years of our 6-year medical course. The other courses are coming on board, but it's taking time because there's not enough time in medical school to learn all the things you need to know now. We no longer teach content, we teach how to learn, because it's impossible. To keep up with all the areas is impossible. And so now our approach is how this is part of your job. This is not somebody else's job. This is part of your job, and you need to be involved. So the assist, valuable and reliable, doesn't mean it's going to be used. I've been pushing this barrow a long, long time, but I'm absolutely confident we're making ground because I have, at a state, at a Commonwealth, and a local level support, but we've still got a way to go. And I'd like to thank the Australian government who pays for me to do this. Thank you.
Robert, thank you so much.
quite impressive. We have one more presenter, my dear friend, Jay Rat, and I'm not going to butcher your last name. There is no way I can do it. She will talk about the relevance of our educational effort during the COVID pandemic and everything that happened. Please come and join me here. We know each other for many years as well, although she's much younger. And it's my pleasure to give you the floor.
Thank you, Dr. Igor, and thank you, ICU DDR, for having me this afternoon. My presentation will be quite quick. I will begin with the situation that Thailand new drug law reform, they emphasize on the health and well-being of people who use drugs, and the use of compulsory drug treatment remain in place, while alternative measures such as community-based treatment and recovery and the psychosocial counseling on the criminal court system have been being developed. And this is a PDF file, I'm so sorry. No, yeah. I'm sorry that I torture you with the PDF. So I will talk about the capacity building in addiction workforce that is impacted a lot as another sector that is the COVID-19 disrupt it, but it cannot afford longer disruption, right? So it has been long struggling for the short staff of addiction workforce in Thailand. So we have to do something during the heat of the COVID. And we adopt the technical assistant model from Addiction Technology Transfer Center and SAMHSA that once funded Chiang Mai University about this kind of model of capacity building. And we do it all three levels of basic TA, targeted TA, and the intensive TA during the COVID-19. I will show you three cases of what we have done during the COVID-19 that we do online training workshop on 2020 for the curriculum called System Management and Case Management for Patients with SUD in the COVID with community-based treatment focus. And we repeat the same curriculum on 2021, and the last one on 2022, we did psychosocial counseling in criminal court system, capacity building for the qualified volunteer in the criminal court. Start with the first curriculum. Why the CBTX or community-based treatment? You know it that the CBTX is the treatment, alternative treatment that costs less and deliver more benefit, right? And Thailand has identified a growing need for capacity building to establish and strengthen the community-based treatment and recovery services. Many local drug treatment systems across the variety of settings lack sufficient staff and the appropriate type level of knowledge and skill to establish and maintain the treatment outside public health settings. So it's a need to build capacity building for the CBTX in the workforce, both health and non-health professional. And that's the reason supported by UNODC and WHO, right? And this is for some idea that we did online the last 2 years. This curriculum lasts for 5 weeks during August to September 2020. And the focal audiences were psychiatrists, family physicians, nurses, public health professional, psychologists, social worker, and health region coordinator under the multidisciplinary approach for substance abuse treatment. There were a total of 250 learners from 13 health regions nationwide. There were 5 main lessons comprises of substance use disorder treatment in the new normal, the severe mental illness with high risk to violence. The third lesson is community-based treatment and harm reduction, recovery, and role of case manager in linking patient with substance use disorder between health system and the community resources. Transform a face-to-face multi-day in-class training and moving to online delivery. Each lecture must be shortened to 15 and 20 minutes each lesson. And in order to keep participants engaged, utilizing the full capacity of video conferencing platform, the slides show you that we apply a lot of new technology tools to deliver the knowledge and skill, cover the 3 layers of technical assistance, start from basic to targeted and intensive. I'm sorry for my typo, it's intensive, not incentive. So you see that we have official website, we have Zoom live lecture and workshop, Facebook private group is also used. We deliver regular information weekly through e-newsletter, and web-based pre-post test comparison was also used. Google Form has been used a lot. And for the intensive TA, we optimize the breaking room for Zoom conference to practice the counseling skill for people dealing with community-based. And like group chat for mentoring, for many questions from learner asked directly to the teacher or the trainer. So there are many ways to deliver the teaching during the COVID-19. Let me read. It's about a web-based pre-recorded lecture, the workshop, the experience sharing, mentoring, pre- and post-test, self-reflection from the learner. And at the end of the training, 5 weeks long, right? Google Forms were used a lot for pre-post test, for learner satisfaction survey, for self-reflection of learner, including 1 month follow-up. And results show very well that the learner have learned. Learning objectives were met, and learners were satisfied with the learning activities we provide during the 5 weeks curriculum. After 1 month follow-up, learners apply the knowledge and skill they received back to their job and shared with their colleagues. And this comes to the showcase number 2 is the same curriculum, repeat again on 2021. We coordinate with the Royal College of Family Physician of Thailand and Northern Substance Abuse Center, Chiang Mai University to deliver this system management and case management for SUD treatment during the COVID-19 CBTX focus. And the learner of this curriculum is the psychiatrist, the family physician, nurses, public health professional, psychologist, social worker, and the health region coordinator under the multidisciplinary approach from 13 region health nationwide. And again, all the online activities repeat the same as the previous years. We adopt as many as the IT tools just to make it useful as possible for the learner. And again, after we finish the online course, the feedback and the follow-up results show that learners were satisfied with this online context of training. And quickly, we come to the third showcase, that is the psychosocial counseling in the criminal court. That is the curriculum, the core curriculum were developed and trained by Galea-Singer Institute, and this is the Forensic Psychiatric Institute under Department of Mental Health, Ministry of Public Health. Why psychosocial counseling? It is because Thai authority decided to reform the drug policy and reclassify drug users as patients instead of criminals. So we have to change a little bit of the attitude of the treatment professional, just to look at the addicts and the drug user as the patient, not the criminal. And then we start this in the court system. The psychosocial counseling clinics are located in the premise of the court of the first instance and staffed by the psychologists, the social workers, and the qualified volunteers who are trained to assess substance use severity and provide counseling psychological support service and over health care referral. And the counselors in the psychosocial clinic in court system are expected to play 3 roles of facilitator, life coach, and psychoeducator to the clients who are wrongdoers charged for alcohol, drug, petty theft, domestic violence cases. At the core curriculum we provide, there are 4 learning modules at total of 48 hours training and practice. The learning module comprises of basic psychosocial counseling knowledge, skill, and attitude, also ethics of the counselor, the management of substance abuse, and the family counseling and group counseling as well. And here are the technology that we use for the curriculum of the psychosocial counseling, covering the 3 levels of technical assistance from basic to targeted and to intensive. So we use Google Drive, Google Cloud Storage, website, Zoom video conferencing, breakout room, Google Form, Line group. With the time limit, so I will leave you the QR code two QR codes. If you would like to learn more about the psychosocial counseling, would you please scan this QR? The upper one will lead you to the booklet concluding everything you need to know about the psychosocial clinic. And the lower QR code is about the UNODC paper that announced that psychosocial counseling in criminal court system is an example for court diversion and as the alternative to incarceration. And of course, in summary, when the COVID hit, we have to change the way we work to continue addiction workforce development uninterrupted. So going online, although many benefits, yet challenges are there, especially adult learning motivation. You all know that, right? In-person or virtual motivating adults to learn is not easy. So we adopt all kinds of methods to motivate adults to learn. Both in career advancement, we try to manage the learning environment to be friendly as much as we can. And also we need prizes and incentives during the courses. We make it a game and give away a lot of gift voucher, food coupon. But the most important is about the career advancement. We chunk the information and focus on practical knowledge and skill. This is the most important. And then we offer the real-world tips and technique. We certificate the completion of the courses, and we offer the continuing education credits, both to medical education credit, nurses, and the public health officer.
Good example of successful advocacy, because as we had a talk yesterday, Central European medical faculties have a same model, 1 day for medical students for addiction science in 6 years. And if we have a successful model or something what was published about advocacy with deans, because for instance we have association of deans and they are completely close to discussion about extending this 1 day to more. This is a question on you. On Dana and Carmel, we are about approaching experimental study on nurses in bachelor program in Central Europe and with 5 faculties. And I would like to ask you, the icebreaker in my case was about discussion about competencies. Without competencies, they were not able and willing to send us on students. And when I define the competencies, I mean new competencies, what they will receive after the course, they allowed. And now we have this experimental course and we will test it on students. And by the way, it's based, Robert, on assist for nurses. And my question is, you mentioned some international exams. Do you have experience with accepting of these exams on the national level? Because, you know, nurses, it's like an army. And if you would like to have something at the national level, it has to be recognizable and acceptable for the system. And especially in Europe, we have very strict regulation, and in US is the same. Do you have some experience with the National Association about accepting this exam at the national level? And to Robert is my last question, sorry. We have a very bad reaction after starting with assist, with pediatrics, because they are very frustrated. They cannot refer adolescents to the specialized services because other services are relucting accept young patients for care. I mean non-specialized treatment. Do you have some model what to do if we don't have enough specialized services? Because in my country we have only 11 specialized outpatient services for kids and adolescents, and no more. It means that in many regions it's not accessible. And pediatrics are very frustrated, and they are reluctant to support more using Assist. We have online training for them, it's accredited and it's fine, but they are always complaining, okay, we will train more doctors, more pediatrics, but where we will refer these patients. Do you have some model? And yeah, thank you. Sorry.
All right, let's give brief answers.
Okay, I'll be very brief. So there are learning objectives that are being accepted as universal. So there's the universal curricula that are being worked on, but I'm not aware of a specific one that's sort of gold standard at this point in time, but that's what's being worked on. And it's true learning objectives. And the way it's being done is very different in different medical curricula. So you get some curricula where they have specific modules on substance misuse. And then you've got other curricula where the learning objectives are intermingled with other modules. So for example, part of neurology or part of psychiatry. And so you're still covering the same learning objectives. And the way they're assessed are also different, which is why I mentioned, and I didn't go into it in my talk, that there needs to be quality standards for all of this. Yeah.
Very big challenge, your question. We are not there yet. I think I agree with you that if the global certification is to be adopted nationally, which is the wish, then there has to be a communication at national level to map that certification to the country so they understand and recognize. So this is where we hope maybe with the affiliation with the ICN through all the nursing organizations that we get them to help facilitate, to support, to sponsor. So this is the beginning of the conversation to go in at national level, but to first set the global and then have the discussion about adaptation. But I agree, it needs to be owned locally in order for it to work.
Wonderful.
Yeah.
Robert?
Initially, the situation at home was quite difficult. Youth suicide changed the difficulty. It became the crisis. The government became very concerned about youth suicide rates, and they opened a variety of community-based mental health services, which were shopfront services, not presenting themselves as psychiatric services, but presenting themselves as services to assist you with your mental health. And we have been able to incorporate our assessment and intervention into them. So at that early intervention stage, I would say, yes, we have become successful. However, the problem that you've identified, which I get phone calls regularly from medical colleagues who say, my child has a problem and I don't know where to send them. And I don't know what to do for them. Where would you recommend I send them? The challenge is that most of our services are aimed at adults. Predatory behaviour happens in those settings. And so what I negotiated was the paediatric hospital, who has a psychiatric ward, would provide access for a few people, with us providing technical support for them in terms of managing the substance use. It's an imperfect solution. The government doesn't have the interest to do it. That's the truth of the matter, you know, because I can make the case, mental health has made the case, they're in the wrong place. But it's better than them going to an adult clinic, a lot better.
Okay, friends, colleagues, let's start closing the session. We are running a little bit out. Don't forget there are some evaluation forms. So the purpose of this session was to start building what we call competencies. in different areas, in different professionals. Let me just remind you quickly, what does it mean building competency? In any, whatever we are trying to do. Imagine, let's talk about driving for a second. If I ask you, is it possible for a newborn to drive a car? You will say no, because the baby is too small, doesn't know the rules, blah, blah, blah. All of these things will be correct. But there is one reason more important than others. A newborn baby doesn't drive, but the baby doesn't care about it. It has no impact on the baby's life whatsoever. The only important thing is a clean diaper and mom's breast. That's all. Driving has no value for the baby. So this stage of competency building, we call it unconsciously incompetent. The baby is incompetent, but it doesn't care. It doesn't make any impact on the life. How about 5, 6 years old? Kids, do they drive? No. Do they want to drive? Yes. They pretend they're driving. My sons did that. So there is a major shift in their competency. They're still incompetent in driving, but they want to learn. They know there is a deficiency in their life. My son, he is 17, just got his first driver's license. So the state, for whatever reason, the state of California decided that he is a competent driver. Is he a good driver? No. No. But is he competent in driving? Well, the state said yes. He got the license. So when you remember your first driving week, the first week of driving, people drive. Most people do it relatively safely, but you're tense, you're scared, you're sweating, you cannot talk, you cannot eat, you cannot do anything, you're just focused on driving, it's normal. So we have to remind ourselves, now don't forget to. So this stage of learning we call building competency, we call it consciously competent. People are competent in driving, but they have to remind themselves they cannot do anything else, they're focused, blah, blah, blah. Most of you have many years of driving. Do you think about driving when you drive? No. No. We can do a lot of other things, have a phone call, have a Coca-Cola, think about something else, and still do it relatively safely. We are so competent that we really don't have to think about it. This phase of competency, we call it unconsciously competent. So a newborn baby is unconsciously incompetent. Most of us are unconsciously competent in driving. So in terms of competency building in our field, partly because of the gathering like this one, we are making a transition in terms of building addiction training competency at that level. We are making a transition from being totally unconsciously incompetent, we don't have it, but we don't care. We are making gradual transition. We are still incompetent, frankly, but we are consciously incompetent. Yes, we know there is a deficiency. Yes, there is something that we need to take care of. We still didn't do a good job, but we are thinking, we are trying. So, and this, even though we all know about the deficiencies that we have globally around the world in building addiction treatment competencies, the major shift that we made, we are not unconsciously incompetent anymore. We are consciously incompetent, and in some cases we are even consciously competent. We are doing something, maybe not the best way to do it, but we are doing something. Something is happening. And it's all happening, this competency building process. Remember, this is a process, not an event. This process is happening mostly because of you people. Thank you so much. Have a wonderful conference, and thank you for listening. Presenters, you are wonderful. Thank you all.
Thank you.